Hello, my name's Simon Hughes. I'm a consultant in radiology and nuclear medicine at the Queen Elizabeth Hospital in Birmingham. I gave a lecture at the British Nuclear Medicine Society Spring Meeting in 2022 on the use of FDG PET-CT beyond the common subtypes of Hodgkin's lymphoma, diffuse large B-cell lymphoma and follicular lymphoma. And I've made a recording for the BNMS YouTube channel for the lecture I gave. I hope you enjoy it. So I started off with my favourite 16th century philosopher, Montaigne, who said, "Que sais-je?" famously, "Que sais-je?" What do we know? So we've had some recent data on the more uncommon lymphomas in the last few years. So I thought we should review what we knew or what we know about FDG PET-CT in these more uncommon lymphomas. WHO 2017 classification gives 20 different lymphomas, but we're really just going to concentrate on 5 of those. The Burkitt's lymphoma, Mantle cell lymphoma, PTLD, peripheral T cell lymphoma, and cutaneous T cell lymphoma. So first of all, let's look at Burkitt's lymphoma. So this is a rare, aggressive subtype of non-Hodgkin's lymphoma. It's associated with the Epstein-Barr virus, and this is prevalent in malarial areas. So it's often a tumour of the pediatric population in which the cure rate is high, but there are still significant toxicity and treatment-related complications. Burkitt's lymphoma in adult population, which is what we see much more of in the UK, making it a much rarer lymphoma, has a very poor outcome. So if we look at a recent study of 189 patients retrospectively assessed for Burkitt's lymphoma, this shows a difference in the outcome of a negative and a positive end of treatment PET-CT in Burkitt's lymphoma. So there's a high negative predictive value for end of treatment PET, with a progression-free survival of 94% and overall survival of 94% at 3 years. And if you increase your assessment to Deauville score 5, then the positive predictive value, which was previously very low because of false positives with Deauville scores of 3s and 4s, if you take it 5, then the positive predictive value is also improved. And again, this is shown in a smaller retrospective study showing that the negative predictive value of end of treatment PET-CT is very high in Burkitt's lymphoma. So here we have a case of very unusual distribution of Burkitt's lymphoma throughout the somatic musculature, throughout the thorax, abdomen, and into the pelvis. But again, FDG PET-CT helped guide the biopsy in this case. If we look at baseline, interim, and end of treatment PET-CT, then we start to see much less usefulness of the interim PET in Burkitt's lymphoma. So we see no significant difference in the interim PET, whether there's a response or not. And if we take the study looking at 61 patients, looking at changes in MTV for both interim and end of treatment, then the changes in interim PET, MTV, and interim PET, total lesional glycolysis, were not related to survival, but the end of treatment, MTV and TLG, were independently poor prognostics of changes for progression-free survival and for overall survival. So in Burkitt's lymphoma, with some recent data, we can say that the end of treatment PET-CT has a high negative predictive value for good response to therapy. That end of treatment MTV and TLG are independent prognostic findings, but the interim PET, no matter how we analyze it, does not appear to be useful in prognostic indications. Let's talk about mantle cell lymphoma. So FDG PET-CT is not included in the consensus recommendation for mantle cell lymphoma because it is often a stage 3 or a stage 4 disease. There are frequent bone marrow involvement and frequent gastrointestinal tract involvement. And it is rare to get limited disease, although PET may be useful in these limited disease cases. And that's what I want to show you. So here's a laryngeal mantle cell lymphoma, and you can see this prominent increased uptake within the right side of the true larynx, and we can see a more return to normal pattern within the larynx. But then hopefully some of you have seen there's focal uptake within the right mastoid airspace, and this is a treatment complication. So if we take 122 patients, nearly all of them were PET positive for this disease, and taking an initial PET-CT change management in about 1 in 5 patients. It had a high specificity for the detection of bone marrow and GI tract disease, but a much lower sensitivity. The Lima MRD project is giving us some data on PET in mantle cell lymphoma. This is a response to therapy assessment with a PET arm for 299 previously untreated mantle cell lymphoma patients. And we can see that the level of SUV max seen at diagnosis and the changes in SUV with the chemotherapeutic regimes that they're investigating were predictive of outcome in mantle cell lymphomas. In this study of 89 consecutive mantle cell lymphomas, the interim PET appeared to be highly predictive of an inferior 5-year overall survival and a 5-year progression-free survival. And they could even put that risk assessment into different categories. So the best assessment was a patient who was interim negative and end of treatment negative, and they had the best outcome. And the worst outcome was interim positive and end of treatment positive, and differences in between. And again, as we develop risk-based assessment treatment regimes in modern lymphoma management, these may become more useful. A study of 97 patients looking at detailed radiomic features showed that these were unsatisfactory. And in a retrospective study of nearly 80 patients, the sensitivity and specificity for the detection of GI tract disease within the stomach, gastric mantle cell lymphoma, was low. So what can we say? We can say that simple qualitative FDG PET measurements are generally predictive of outcome. It leads to change in management in mantle cell lymphoma, and that interim PET appears to be useful in mantle cell lymphoma, looking for overall survival as well as progression-free survival. What if we want to look at post-transplant lymphoproliferative disorders? What can we say from some recent data on these? diseases. They are a heterogeneous group of diseases and often present with extranodal disease, including some CNS involvement. Most are B-cell lymphomas, that the pathological assessment can be difficult and clear separation is not always possible. But again, this pathological characterization of PTLD is becoming more important. So if we look at a systematic review and meta-analysis of 336 transplant recipients, the PET was very good at detecting the disease, the burden of disease, and the site of disease. And again, this is important when we start to want pathological samples, that there was a good inter-observer agreement on where that disease was. And what it says here, that the findings in the post-transplant period with FDG PET-CT is usually of clinical benefit, it says behind me there. So, using FDG PET-CT in the early stages of PTLD seems to be useful. So here's a patient, there's the right iliac fossa, renal transplant, there's the prominent focal uptake within the GI tract thickening, the symptomatic disease, and we see relative resolution of that disease at end of treatment assessment. So, what can we say about using those interim and end of treatment PET scans in PTLD? So in a group of 41 patients, there was no significant difference in overall survival, progression-free survival or time to progression between negative and positive patients. And in a larger study over a much longer period of time, there was some difference in 3-year overall survival, 91% versus 57% in those who had some detectable disease at end of treatment, but the complete remission rate was 76%, so really struggling for any real data to guide us, a little bit in the dark. So in post-transplant lymphoproliferative disorders, we can say this is an uncommon, we can say that in this uncommon lymphoma, that FDG PET-CT is useful in the detection of the disease, and this can be important in guiding of biopsies. But real uncertainty about the utility in interim PET and end of treatment PET in providing useful information. So let's talk about peripheral T-cell lymphomas. This is a heterogeneous group of peripheral T-cell lymphomas. The most common are angioimmunoblastic T-cell lymphomas and the peripheral T-cell lymphoma not otherwise specified, PTCL and OS. The overall survival is poor, so the best ones are the ALK positive anaplastic large cell lymphomas, but the angioimmunoblastic T-cell lymphoma here, just behind my head, it says about 35%, 5-year survival, and for the PTCL not otherwise stated, it's near 25%, so really quite poor outcomes in these T-cell lymphomas. So in a group of 40 patients, the vast majority were FDG positive, but interim and end of treatment PET response was not predictive of progression-free survival or overall survival. In a larger group of 124 patients, again with a 5-year survival of about 50%, lung and liver involvement was a worse outcome, but interim PET was not predictive of overall outcome. So here I just want to show you what looks like underwhelming, but there's this T-cell nasal lymphoma, a peripheral T-cell lymphoma we often see with PET-CT, and one I've seen frequently, partly because of the way they present. They often present with a mass in the nose, and we are helping to assess that, or they get a lymphoma and we see this limited disease. How about more subtle assessments? So if we're really struggling in qualitative assessment, maybe metabolic tumor volume or changes in metabolic tumor volume might be useful. So here we are, so 31 patients in this not otherwise specified really poor group, that the presence of Deauville 5 was an independent prognostic factor for progression-free survival, and that the metabolic tumor volume was an independent prognostic factor for overall survival. So in this very poor outcome disease, maybe MTV is going to help us. And in a larger group of patients with a more mixed pathology, we see that high MTV predicted a much poorer 2-year progression-free survival, and even a poorer overall survival. And that on multivariate analysis, it was metabolic tumor volume that was a significant parameter for progression-free survival and overall survival. So again, we're seeing this more detailed analysis coming into this assessment. If I want to show you here a case of a PTLD in a parotid gland that had been biopsied and was confirmed. The bone marrow biopsy was negative, but they sent it to us, and we showed focal uptake within one of the right ribs and within the L5 vertebral body. And if this has been looked at specifically in these two patients in which the PET scan is not a replacement for bone marrow biopsy, in that the overall sensitivity and specificity for low cellularity is low, but a relatively frequent occurrence is focal bone marrow uptake, and that the detection of bone marrow uptake either in a diffuse pattern or a focal pattern was an independently poor prognostic finding. So we can see that the qualitative imaging detects the disease but doesn't really add any more information, but the metabolic tumor volume assessment does appear to be predictive of progression-free survival and overall survival. It may be useful in risk-adapted therapies in the future, and that focal bone marrow uptake is an independently poor prognostic finding and can be useful even with a negative bone marrow biopsy in these patients. Let's look at cutaneous T-cell lymphoma, a particular interest of mine. So the commonest are the T-cell lymphomas, although we do see cutaneous B-cell lymphomas. These are rare, but they are difficult to manage and difficult to treat, and usually done in specialist centres. But we need to improve the accuracy of the diagnosis, the staging, the treatment response, and the monitoring of recurrence. So is PET going to help us? There are lots of criteria around these very rare tumours. The clinical assessment remains vital, but one of the important things is the detection of N3 disease, so this is a pathological criteria of the presence of disease which dramatically reduces the prognosis of the patient, and where the 1-year survival is often near 50%, whereas with other types of disease and other stages of disease, much, much better. So here we see the kind of pattern that you can see with this disease, and so you can see these thickening of the skin on the CT component, and you can see this prominent FDG uptake within this disease, and we see some FDG uptake within some small and enlarged axillary nodes. So we wanted to look at that. We looked at that internationally, and this is just a small poster we've presented showing that that the PET scan, both the size and the FDG uptake, was not predictive of the N class, predictive of this N3, this very poor prognostic N3 criteria that we're interested in these rare lymphomas. And if we look at N0, so normal nodes, 1 and 2 disease, or N3 disease, we can see that the long axis of the node doesn't appear to be any different between these two groups. The SUV mean and range doesn't seem to be different. And in total volume of nodal disease, there's a trend towards larger volume disease, but no significant difference. So these are the kind burden of disease that we've seen, very high, very high burden of disease. Often we don't detect any disease, that we can't see the disease and the clinician can see, but we can see these dramatic progressive changes, and we see these very high volume of skin disease and these large nodes. What we think and what we are going to try and look at is an assessment of the burden of the skin disease as a prognostic finding in cutaneous T-cell lymphomas. So in cutaneous T-cell lymphoma, we are struggling to use PET to diagnose this very important N3 nodal status, the very poor prognostic finding, and that we're going to look at measuring the real burden of detectable PET disease. Maybe that will help us define some of the risk assessments. So there's a very quick review of some of the more up-to-date data on these rare lymphomas. When I teach, I often teach that there's no such thing as the surely moment. Surely it's hot, surely that's bad. Surely it's cold, surely that's good. We can see that we must try and deliver evidence-based practice, and that evidence of Hodgkin's lymphoma is not applicable to all of these subtypes of lymphoma. So we can see the staging PET, the interim PET, and the end of treatment PET, that their utility varies across these uncommon lymphomas. But we can see a little bit of a trend towards MTV assessment being increasingly important, and maybe other radiomic assessments, but as we've seen, not all of them are successful. So I hope you find this recording of the lecture I gave at the BNMS Spring Meeting useful. Thank you for choosing the YouTube, the BNMS YouTube channel. Thank you very much.